In this presentation, I will discuss psychopharmacology of depressive disorders. I will discuss some basic concepts regarding commonly used drugs and their mechanisms of action. Serotonin, norepinephrine, and dopamine systems will be discussed, which are very important to understand current psychopharmacology of depressive disorders. A study by the World Health Organization ranked depression as the fourth global burden of disease, found it to be the largest non-fatal burden of disease with nearly 12% of total years lived with disability. Here are some studies listed regarding current and lifetime prevalence of major depression. In a cross-sectional WHO survey carried out in all regions of the world, the 1 year prevalence of a depressive episode was 3.2%. In patients with several medical conditions, the prevalence of depression exceeds that of the general population, with 5 to 10% of patients affected in primary care and 10 to 14% of patients under general hospital care. 50 to 70% of patients with depression in primary care remain undetected, with somatization being one of the most important single problem associated with the misdiagnosis. Although drugs and general medical conditions such as hypothyroidism, Huntington's disease, Cushing's disease, and Addison's disease do not represent a substantial public health problem as a coil factor for depression, management, when appropriate, must be directed at the underlying condition as well as depressive symptoms. I will move on to current understanding of uh, depressive disorders and neurotransmitters involved in these mechanisms. Three monoamines are hypothesized to be involved in behavioral symptoms in mental disorders: serotonin, norepinephrine, dopamine. Serotonin is produced in RAF nucleus. Serotonin is synthesized from tryptophan. Tryptophan hydroxylase is the rate limiting enzyme in this process. Tryptophan get converted to serotonin, which is metabolized to melatonin. Norepinephrine is produced in nucleus coeruleus. Dopamine is produced in ventral tegmental nuclei. All these nuclei are located in midbrain. The red dot in this cross section is the area where RAF nucleus is located. RAF nucleus is involved in producing serotonin, and it is located in midbrain. There are some important areas in brain which are currently understood to be involved in depression: frontal cortex, regulate mood; basal ganglia, involved in akathisia, agitation, OCD; limbic system, anxiety; hypothalamus, appetite, bulimia; sleep center, involved in insomnia; spinal cord, involved in sexual dysfunctions. In this cross section, the yellow area is locus coeruleus, which produces norepinephrine. The red area is ventral tegmental area where dopamine is produced. Frontal cortex is involved in mood, attention, concentration, working memory. Limbic cortex is involved in regulating energy level, agitation, emotions. Limbic system has significant importance in emotions, mood, anxiety, and depression. Amygdala in limbic system is involved in aggression, jealousy, and fear. Cingulate gyrus, autonomic functions regulating heart rate, blood pressure, as well as cognitive and attentional processing. Fornicate gyrus, regions cons- encompassing the cingulate, hippocampus, and parahippocampal gyrus. Hippocampus required for the formation of long-term memories. Hypothalamus regulates the autonomic nervous system via hormones, productions, and release. Affects and regulate mood, affects and regulates blood pressure, heart rate, hunger, thirst, sexual arousal, and sleep-wake cycle. Mammillary body important for the formation of memory. Nucleus accumbens involved in reward, pleasure, addiction. Orbitofrontal cortex important in decision making. Parahippocampus gyrus involved in formation of spatial memory. There are some other important areas in brain such as dorsolateral prefrontal cortex, which is supposed to be the executive headquarters of body, involved in planning, motivation, foresight, feedback. Orbitofrontal cortex involved in remorse, insight, judgment. There are some receptors which are involved and significantly affect the side effects related to antidepressant medications. Alpha 1 involved in lowering blood pressure and may cause dizziness. H1 causes weight gain and drowsiness. M1 constipation, blood and dry mouth, drowsiness. Alpha 2 is a very interesting receptor. It is presynaptic or receptor. It is present on noradrenergic and serotonergic neurons and is activated by norepinephrine, leading to decrease in both norepinephrine and serotonin. Blocking of alpha 2 will lead to an increase in both norepinephrine and serotonin. Mirtazapine, Risperidone, clozapine, quetiapine, aripiprazole block alpha 2 and thus increases both norepinephrine and serotonin. That is one of the mechanisms how antipsychotics work uh, as an antidepressant and can be used as adjunct in treatment. There are several 5-HT receptors. 5-HT1A and 5-HT1D are presynaptic, or others including 1A, 1D are postsynaptic. With the exception of 5-HT3 receptor are ligand-gated ion channel, all other 5-HT dopamine, acetylcholine, norepinephrine receptors or G-protein coupled receptors and act on the intracellular second messenger cascade. When antidepressant treatment is started, 5-HT rises to a much higher level at the cell body area in the midbrain reef nucleus than at the axon terminals. Side effects appear to be mediated by the initial effect of 5-HT on its receptors. However, later on, the receptors get desensitized around the time of the full effect of SSRI. 5-HT2A receptor is involved in many side effects related to antidepressant treatment. Acute stimulation in basal ganglia can lead to akathisia, psychomotor retardation, mild Parkinson symptoms, and dystonic reaction. By acting on sleep center, this can cause myoclonus during night, disrupt slow wave sleep, and cause nocturnal awakening. Its activation in spinal cord can cause decreased libido and problem with ejaculation. Actions in player centers can lead to decreased dopamine activity, apathy, and decreased libido. It is also important in atypical antipsychotic mechanisms of action. 5-HT2A and C uh, work in RAFE to limbic projections, may cause acute mental agitation, anxiety, as well as panic attacks. 5-HT3 affects hypothalamus, leading to nausea and vomiting. 5-HT3 and 4 act in GI tract and may cause increased mobility, cramps, and diarrhea. Here are some receptor actions related to antidepressant treatment. Tricyclic antidepressants or SRI, NRI, and inhibit M1, H1, and alpha 1. Here are some common antidepressants which are used to treat depression: citalopram, Celexa, SRI, fluvoxamine, SRI, sigma agonist, inhibit cytochrome P450, 1A2, and 3A4, Zoloft or sertraline, SRI, DRI, sigma agonist, Paxil or paroxetine, SRI, NRI inhibits cytochrome P450, 2D6, and 3A4, fluoxetine or Prozac, SRI, NRI, 5-HT2C antagonist, inhibitor of cytochrome 2D6 and 3A4, mirtazapine blocks, uh, alpha 2, 5-HT2A, 5-HT2C, 5-HT3 also blocks H1, which is attributed to its side effects. Trazodone SRI blocks 5-HT2A, blocks alpha 1 and H1. Nefazodone SRI NRI block 5-HT2A alpha 1 blocker. Duloxetine or Cymbalta SRI NRI, bupropion NRI DRI. Venlafaxine shares the properties of classical tricyclics such as SRI, DRI, NRI, but without alpha 1 cholinergic and histamine receptor blockade. Buspirone, partial agonist of 5-HT. Now I will move on to management, which depends on which setting we are treating the patient. More than 80% of patients with depression are managed and treated in primary care. We need more detailed information. What would be done if patient has depression with psychotic features, with, with severe catatonic features or atypical features? When is psychotherapy indicated? How much is the placebo effect with antidepressants? Here are some common SSRIs and their starting doses and maintenance doses. Here are some tricyclic and tetracyclic antidepressants with the starting dose and maintenance dose. Amitriptyline, clomipramine, doxepin, imipramine, disipramine, nortriptyline. MAOIs is another class of medications which are used sometimes for depression, especially in treatment refractory depression, and it consists of irreversible non-selective blockers and reversible inhibitors. There are significant interaction and side effects of MAOI inhibitors when mixed with other medications. Therefore, it is important to regulate their starting with the discontinuation of other antidepressant, and this is a useful chart in this regard. Antidepressants are only modestly effective in depression. STAR-D trial showed that only one-third of patients remit on their first antidepressant treatment. Even after a year of treatment with a sequence of 4 different antidepressants given for 12 weeks each, only about two-thirds of patients achieve remission. So there are limitations to antidepressant treatment. Thank you very much.